Hello, I'm Jay Shubrook, a professor at Tuttle University, California, and today we're going to talk about diabetic kidney disease. And I'm happy to have with me Dr. Katherine Tuttle, who's a professor of medicine at the University of Washington, a very active principal investigator in the world of diabetes and diabetic kidney disease, and on the KDIGO Guidelines Steering Committee. It writes the guidelines for really how we manage chronic kidney disease. Dr. Tuttle, thanks for joining us today.
Thank you. It's a pleasure to be with you here today.
So, when I think about diabetic kidney disease, I think about my annual screening for albuminuria and how important it is in diabetes specifically, but also in hypertension to be screening for that. But I'm starting to hear that maybe there's more to this than just albuminuria. What can you tell me about that?
Well, yes, albuminuria is very important because it's often the first harbinger of kidney disease, but also of cardiovascular disease. However, it's important to also assess the estimated GFR based on a serum creatinine measurement, because many people with diabetes can present with kidney damage or kidney disease even without albuminuria. And we've really seen a shift in the phenotype over the past 20 years to where there are fewer patients presenting with albuminuria and more presenting with low GFR without albuminuria. We're not sure of the reasons, but in a study that we did where we looked at the National Health and Nutrition Education Survey that's done on an annual basis by the CDC, we did find that there is greater use of ACE inhibitors and ARBs. Glycemic control has improved in the population as reflected in lower A1Cs. So while these therapies may help to reduce or extinguish albuminuria, they may be masking kidney disease in a sense that GFR is still declining even when albuminuria is low. Okay,
so that highlights a couple important things. So when we do our annual screening, we're really looking at eGFR and albuminuria, and they both carry weight in relation to diabetic kidney disease and cardiovascular disease?
Yes, particularly albuminuria is a marker of endothelial dysfunction. Expressed at the level of the kidney, it results in albuminuria because of leakage into the urine. But this leakiness of the endothelium is present systemically as well. So it's a harbinger of systemic vascular disease, particularly atherosclerotic disease, that can be detected by a urine test of albumin. Low GFR is also a risk factor for atherosclerotic disease and other forms of cardiovascular disease, including heart failure. And this may relate to the relationship between the kidney and the heart and the importance of the kidney in producing damage to the circulatory system.
So it's all connected. I guess we always know that, right? The body's a unit. We know that all things are related. So let's say I have a patient and I start to see the creatinine climb, but I also have levels of protein excretion in the urine. How do I determine how severe someone's kidney disease is?
Well, it's a combination of looking at both the amount of albumin in the urine and the GFR. For the KDIGO group that you referred to, we have produced what's called a heat map of risk that has stratification based on both albuminuria and GFR. And basically, the lower the GFR and the higher the albuminuria, the higher the risk. But even before GFR declines, high levels of albuminuria alone markedly increase risk. Risks of what? Death, kidney disease progression, but also cardiovascular events.
So don't forget the significance of albuminuria as a marker of systemic disease, what I'm hearing you say.
Exactly.
Okay. And so when I have that, what can I do about it? Because again, I get a little worried if I have a patient that has maybe a lot of protein excretion, but maybe their eGFR is normal. Is that the same? How does that work out? And then what do I do?
Well, risk increases when GFR declines, so both add to the risk. But albuminuria alone is a significant risk, but combined with low GFR, it's even greater. So I think the first things that we want to do is look at conventional risk factors and optimize control. So with regard to blood pressure, in people who have elevated levels of albuminuria, even more than 30 milligrams of albumin per gram of creatinine in a spot urine sample, we recommend a target blood pressure less than 130/80. so below the conventional threshold. And this is based on trial-based evidence showing that patients with higher level of albuminuria do benefit from a lower blood pressure in terms of preservation of life as well as kidney function. And with regard to choices of medications, either an ACE inhibitor or an angiotensin receptor blocker are preferred because, again, above and beyond the blood pressure control, they provide kidney and cardiovascular protection. But what we did learn in trials is that more wasn't better. So combining an ACE and ARB together actually causes more harm than good, and that's related to side effects, particularly acute kidney injury and hyperkalemia. So one or the other, but not both. With regard to glycemic control, again, we recommend intensive glycemic control if it can be accomplished without significant risk of hypoglycemia. That gets to be a problem as GFR declines because hypoglycemia risk goes up so much. So when GFR is low, particularly below 45, that risk really increases. So then we often recommend a higher A1C than for the rest of the diabetic population. So while in general we say less than 7 if it can be accomplished safely, once GFR is low, we're probably looking at a A1C above 7. Nobody knows what the ceiling should be because we haven't done a study to test that, but practically the ADA and KDIGO recommend not above 8. So probably somewhere between 7 and 8. And the nuance of that is going to have to be made at the individual patient and physician level to look at their total risk profile and decide, you know, where within that range they should be. So that is conventional treatment, but the truth is, even with the best conventional treatment, we still see many people progressing. I'm going to, you know, map back to what I talked about earlier with the NHANES data showing us that even when we intensify glycemic control, blood pressure control, use ACEs and ARBs, we can reduce the albuminuria, but we still have people with low GFR and who are progressing. So it's not the whole story. I think what's really exciting is that there are some new agents that look like they're going to be very promising for preventing GFR decline, and those are the newer glucose-lowering agents, particularly the SGLT2 inhibitors, but also the GLP-1 receptor agonists are looking very promising in terms of preserving kidney function. So that's really quite exciting, and I think will add to the armamentarium of kidney protection.
Wow, there's so much there that's so important. So remember to do our annual screening, both for eGFR and for albumin excretion. Remember that either one can be a marker of bad things to come, and that we should be addressing that with our conventional treatments. But stay tuned, there'll be more information coming soon about kind of the powerful impact of potentially new glucose-lowering agents to treat not only diabetes, but diabetes kidney disease. Thank you so much, Dr. Tuttle.
My pleasure.